for Lobo, sir?
He will join in between, so no problem. We can start in the meantime. I'll be like trying to connect Lobo, sir. Yeah. Yes, we are good to start, sir.
Yeah, I'm okay to start.
Good evening to everyone. Welcome from the Yashoda group of hospitals. Every Tuesday we are conducting about the topics which are interested and common interest for the critical care people, along with the allied specialties and emergency people. In the same way, today's topic for discussion is there about filters in ICU. What is new? Regarding the filters in ICU, when we talk, a lot of people talk about only for the dialysis. But today's main topic for discussion, other than the dialysis, what filters are used and what is their utilization is day-to-day practice is important. For this topic to speak, we have our colleague who is the senior intensivist and head of the Department of Critical Care Medicine, Dr. KEM Misra, who will take us through about the introduction of the topics and give us overall idea about what are the filters in the ICU, what is the status. And to discuss further, we are having an expert panelist, our senior colleague, Dr. Rajasekara Chakravarthi, sir, who is the clinical director and nephrologist and transplant physician in Yashoda group of hospitals at Hitec City. And one more expert doctor, the Dr. Valentine Lobo, who is consultant nephrologist at KEM Hospital, Pune. First, I request Dr. KC Misra to go ahead with his presentation, and subsequently we have the panel discussion, and whatever the people who are joined, their queries are there. They can put their question answers in the chat box so that we can have further discussion. With this, we'll start. I request Dr. KC Misra to go ahead with his presentation. Over to Dr. KC Misra.
Thank you, sir. Thank you for the introduction. Just a second.
I think just I'll take 1 minute. Dr. Valentine Lobo sir has joined, I think. Welcome to Lobo sir. Hello, sir. I think some issues are there. Misra, you can go ahead with the presentation.
Yeah. Good evening, everyone, and thank you, Madhusudhan sir, for your kind words. So the topic, extracorporeal filters in ICU, like as Dr. Madhusudhan sir told already, see, most of the time when it comes to extracorporeal therapy in any form of ICU, the most common one is renal replacement therapy. But there are many other things what we use, may not be that commonly, but yes, we use more on and off in a month few times. And there are like good amount of data, but recent data, there are some positive data and some negative data, what we are trying to go through today. What I will try today is to go like brush through few of the things which will be important for the students or the junior people. In the meantime, I will try to focus on few things. It is a very large topic to cover in that stipulated time of 20-30 minutes. So I will try to brush upon and touch upon most of the things if possible or time permits. So basically, what do you mean by extracorporeal? Extracorporeal is any form of treatment which is situated or occurring outside of the body. Extracorporeal treatment is a heterogeneous group of treatment which promotes removal of endogenous or exogenous poisoning. It supports some failing organ, either temporarily or replacing a vital organ function, what we usually see in ECMO patients, or combination of both these two. When it comes to filters, so different filters what we use in ICU, one is, as I have told, like renal replacement therapy. The other ones what we use is hemoperfusion, plasmapheresis or plasma exchange, ECMO, cardiopulmonary bypass is the bigger form of ECMO. ECMO and cardiopulmonary bypass and maybe plasmapheresis. Today we'll try, if possible, we'll try to talk on plasmapheresis, but ECMO and cardiopulmonary bypass will be too vast to cover in today's topic. So basically, like this is one of the important slides to understand, like as per the solute size, different forms of your extracorporeal therapy will work. So different solute size will determine what kind of extracorporeal therapy we should go for. If the molecular size is less than 500, we say it to be small molecules. Usually these are the urea, creatine, phosphates, and most of the electrolytes, which can be removed by any form of extracorporeal therapy. Let it be your dialysis or your filtration, or maybe a hemoperfusion, or even your plasmapheresis. The middle molecules, which sizes goes from 500 to 15,000 Dalton, these are the molecules which are of interest today, what we are going to discuss, different forms where it can be utilized. These are the endotoxins, cytokines, some drugs like vancomycin, insulin, and vitamin B12, which are larger molecules. Even larger molecules are more than 15,000 Dalton. These are the mainly the different forms of your proteins like myoglobin, albumin, transferrin, erythropoietin. When it comes to albumin, globulin, and all those things, those sizes goes beyond 60,000 Dalton. One more important point when it comes to removal of the toxin or removal of the endotoxin or cytokines is important how they are avidly bound to proteins, and how if some drug or some poison which is highly protein bound, it becomes very difficult to remove with most of the regular renal replacement therapy, because protein cannot be removed by your dialysis, hemodialysis, or hemofiltration. Those kind of highly protein bound drugs or toxins can be removed only by hemoperfusion or plasmapheresis. Volume of distribution again is very important. Any drug or any toxin which has a significantly high volume of distribution, those things cannot be removed adequately when it comes to any form of extracorporeal therapy. So when you are doing extracorporeal therapy, only a fixed or very less amount can be removed at some point of time. Then again there will be equilibrium between the tissues and the blood. Then again we can do a second cycle to remove few. So volume of distribution has to be less, and the drug has to be less protein bound to be more to be removed effectively when it comes to any form of extracorporeal therapy. And size does matter. Coming to a few slides about renal replacement therapy, I'm not going to go into detail of that. So you see, renal replacement therapy can be divided into two main types. One is hemodialysis, which works on the principle of diffusion. The driving force here is concentration gradient. As per the concentration gradient, the solutes will move across the transmembrane permeable membrane. Hemoperfusion, which works on the convection, here the driving force is the transmembrane pressure. Here what happens, the solvent will be filtered out as per the transmembrane pressure or driving force. While the solvent is being filtered out, it will drag some solutes with that, or that is called solvent drag. The solutes here, maybe some of the middle molecules can be filtered out, whereas in hemodialysis, mostly the small molecules will be filtered out, middle and large molecules cannot be filtered out. In convection and hemoperfusion, small molecules will be easily filtered out, and few of the middle molecules also can be filtered out when it comes to convection way of method or for hemofiltration. If you see hemodialysis, hemofiltration, most of the things are more or less same how it works. The only the difference is the rate of blood flow. If rate of blood flow increases, the dialysis or hemofiltration will increase the membrane properties. When it comes to hemodialysis, higher low flux membranes are there, which will have higher pore size, will decide about which kind of molecules can be filtered out. Rate of flow of dialysate is again important when it comes to hemodialysis. The more the dialysate flow, the more molecules can be removed, and membrane surface area. When it comes to hemofiltration, the hydrostatic pressure gradient is again very, very important. The more the pressure gradient, the more the solvent will be filtered out. With that, the solvent drag will be happening. So more things can be filtered out if the hydrostatic pressure gradient is more. Permeability of the membrane and surface area of the membrane is more important when it comes to hemofiltration. When it comes to hemoperfusion, what do we mean by hemoperfusion? Basically, we need to understand, to know more about hemoperfusion, is a basic thing called adsorption and absorption. Adsorption is when an atom or molecule or then we call it to be absorption. But when the atom molecules are not getting absorbed or not going into the bulk volume, in those cases they are settling down on the surface, then we call it to be adsorption. The hemoperfusion method is on the basis of adsorption. So adsorption or hemoperfusion is a blood purification modality that where that anticoagulated whole blood will pass through a device or column where the adsorbent particles will be there. Here the toxins, poisons, or cytokines in septic patients can be removed. When it comes to adsorption, there is no ultrafiltration and there is no acid-base equilibrium. Mostly the things what we use for hemoperfusion are activated charcoal and different forms of resins. When it comes to activated charcoal, this usually what they use is coconut shell because it has it is neutral to the body, it doesn't cause much of reaction with the body. In the meantime, it has significant surface area and porosity, which helps in significant amount of poison or drug to be absorbed, not absorbed, absorbed to the surface area. The most commonly used is adsorba or the charcoal hemoperfusion what we use. When it comes to resin, resins can be ionic or non-ionic. Non-ionic, most commonly available one is styrene divinyl benzene copolymer, different forms of non-ionic one which you are using nowadays, because ionic form of resins causes a lot of reaction to the body. So that is the reason nowadays what we use most of the time, resin filters are mostly non-ionic. Which are the factors which affects absorption? The affinity of the drug for the absorbent, the surface area of the absorbent is very, very important. Nowadays, the resins what has been used for in septic patients and all, they have very significantly high surface area. Sometimes it is 45,000 square kilometers. So it is something like unbelievable. Absorptive capacity of the absorbent is very important. Rate of blood flow through the absorbent. The more the blood flow, more the drug or toxin will be absorbed. And equilibrium rate, as I've told, like let's say volume distribution is significantly high. There has to be it has to be get equilibrated from the tissue and blood. So it takes more time. The volume distribution is more. It takes less time. The volume of distribution of the drug is less. Commonly available HP filters options are like from Asahi Hemosorva, which is a charcoal-based immersion cartridge. Gambro, which is more commonly available nowadays. Actually, we are finding difficult to find a this activated charcoal filter, the Gambro, what we used to use before. Tora Industry, that is Toramycin, and Cytosorb, and Jaffron Medical has different forms of hemoperfusion cartridges like HA 130, 230, and 330. Apart from that, there are other available in India. This is from up to date, which is available in US. The Hemophil is one of the things which is available, and Terra Nova one is a high cutoff membrane kind of thing, which is again available in Indian scenario for use. Coming to extracorporeal treatment for sepsis, which we know that sepsis is one of the most common condition what we see in any ICU. Maybe if you see like 20 patients are there, maybe 10 patients out of them will have some form of sepsis. Sepsis, as we all know, it is a life-threatening organ dysfunction due to a dysregulated host response to the infection. It's not the infection which causes the problem, it is a dysregulated host response which causes the problem. So that is the reason there are few hypotheses being postulated. One of the important hypotheses which postulated by Ronco et al. Was cytokinetic peak hypothesis. What they believed is during a sepsis, there will be anti-inflammatory and pro-inflammatory cytokines which will be released. When they go beyond some toxic threshold, that causes significant damage to the body or dysregulated host response. So what they believe, by doing a hemoperfusion where we can remove both pro and anti-inflammatory cytokines, we can always keep those thresholds below the toxic threshold, so the organ dysfunction or organ damage will be less. This is one of the beautiful hypotheses what I felt. Then one more hypothesis which was told by later Horner and Madsen, that is cytokinetic model. What they told is once you do some blood purification and hemoperfusion method, by that what you can do is you can restore the cytokine gradient between the blood and the infected tissue, which is more important for the drugs to get affected. By that what happens, the drugs, the leukocyte chemotaxis will increase. If you see in this picture, these are the leukocytes. Here the numbers were less, here the numbers were more. After a blood purification, the cytokines numbers will come down and your cytokine concentration gradient also will come down. Because of that, the chemotaxis of leukocyte will increase, and maybe because of that, the improvement chances will be improved. So because of these are the two important or most commonly postulated hypotheses, because of which they felt that in sepsis, hemoperfusion of different forms of hemoperfusion may help in controlling the cytokines, which is the major form of organ dysfunction in a patient of sepsis. Coming to different the modalities of like extracorporeal therapy, which has been tried in septic patients. One of the important or earlier tried thing is high volume hemofiltration or through a high flux membranes. Here they have tried high volume hemofiltration where the dose is around 25 to 35, or very high when the dose is more than 35 ml per kg per hour. Most of the studies they used almost 50 to 70 ml per kg per hour through a high flux membrane. By that, what we believe, the pore size is significantly larger than the common dialyzed pore size. It's around 10 nanometer here, because of which the middle molecules, which are the molecules of interest, like our endotoxin, this chemokines, cytokines, and endotoxins, everything can be removed. But the studies, if you see, there are many studies ranging from 2000 to 2013, what I postulated in one slide here. If you see, they are not very big studies. They are like 10, 20 patients has been there in the studies. Most of the studies are prospective. Few are only randomized, or retrospective studies are also there. What they have seen in the initial studies, there is some improvement in mortality, which is like clinically significant. And hemodynamic improvement is more often you have seen in most of the studies. Wherever the latest study, which was the Ivory study, that high volume versus standard volume hemofiltration for septic shock patients, there that ultrafiltration flow rate, what they have studied was 35 versus 70 ml per kg per hour during a 96-hour period in 140 early septic shock patients with AKI. There they didn't show much of mortality benefit, let it be 28 days, 60 days, or 90 days. Even the secondary outcomes also with high volume hemofiltration didn't show much of benefit when it comes to secondary outcome, like ventilator free days, or RIT free days, or vasopressor free days, or length of ICU stay. After that, at this point of time, we are not very sure how like frequently we should use this high volume hemofiltration when it comes to sepsis or septic shock. Then comes the high cutoff membrane. Here, the pore size even larger, which is almost 20 nanometer. In your high flux membrane is around 10 nanometer. Here, the focus, what they have tried to study is the use of this high cutoff membranes in CRRT patient in context of sepsis. Mostly they've used convective modalities to maximize the high cutoff membrane ability to remove pro and anti-inflammatory mediator. In the meantime, by convective method, the loss of excessive albumin, because the pore size is so big that it can filter out albumin also. With convective method, the loss of albumin is little less compared to your diffusive method. And it's not only the high cutoff membrane is used only in sepsis, it can be used in different forms of AKI, like in rhabdomyolysis, myeloma. These are bigger molecules, can be removed by high cutoff membrane. One of the high cutoff membrane what we have used in few cases is Terranova, and one more membrane is also available. Right now I'm not able to recollect the name. There are again many studies from 2003 onwards. Today 25-30 patients only. When in the initial studies, they have seen one or two things. Typically, the IL-6 level or this leukocyte IL-6 and 8 levels are significantly decreased when they have done a high cutoff membrane they've used when it comes to sepsis patient. And there is some significant improvement when it comes to mortality and all. But the latest study, which was the high cutoff sepsis study, which was I think published in 2018, here it didn't show much of benefit when it comes to mortality in 28 days. So high cutoff membrane, the mortality was 31 versus conventional is 33%. So there is no significant improvement, and even the difference between the vasopressor requirement or ICU length of stay also it didn't show much of improvement when it comes to HCO. So high cutoff membranes. And then comes different forms of hemoperfusion methods what we are using nowadays when it comes to sepsis and severe sepsis, septic shock patients. So this is an overview of different modalities what we use. One of the important thing, toramycin, which is a polymyxin B immobilized fiber, which used in sepsis and septic shock patient. Usually it removes endotoxins. They suggest to use 2-hour session daily for 2 consecutive days. Here the heparin need to be used in anticoagulation. And polymyxin B, because it is embedded with polymyxin B, it has some antimicrobial effect also. The second more important thing which is used more often, and now there are new studies are coming up with cytosorb. Here it has been used for sepsis, septic shock, in cardiac surgery patients with SIRS. It can remove many things, not even like cytokines, chemokines, anaphylatoxin, myoglobin, bilirubin, toxins, metals, and many drugs also can be removed with cytosorb. Here what they have suggested is you can use cytosorb in any form of dialysis machine, let it be a CRRT or normal dialysis machine also can be used. It should be given over 24 hours daily, maybe one cycle, or sometimes they've used multiple cycles up to 7 consecutive days also they've used, but there is no clarity how many times you are supposed to use in any patient. Here again, anticoagulant need to be used. The only thing interesting part here is a very large surface area when it comes to cytosorb. Oxyrix, this is again been used. Nowadays we are using in a few of our cases, severe sepsis and septic shock. Here we can remove both endotoxin and cytokines. And LPS adsorber and HA330. HA330 is from the Chinese company called Jafron. So LPS adsorber we are not using much. We don't have much of like experience with LPS adsorber. Usually it removes endotoxin like our toramycin, whereas HA330 can remove cytokines, complements, and free hemoglobin. It doesn't remove endotoxins per se. So these are the different modes that I've discussed right now. Coming to the toramycin actually initially it's shown significant promising results, because of which a lot of studies came. Like it is a cartridge which contains polystyrene based composite 2150 with polymyxin B. So they recommend to have hemoperfusion treatment only 2 hours, twice, 24 hours apart. This is how it has been done. So you can normally like a you can keep a hemodialysis catheter, and through a dialysis machine that blood need to be flowed through this toramycin cartridge. Here, interestingly, it removes only endotoxin. It doesn't remove cytokines or any other drugs and all those things. Endotoxin, as we know, it is a very important or very dangerous thing when it comes to a sepsis patient, and more so with a gram-negative sepsis. Normally in a gram-negative sepsis and in the intestinal tract, they can have 25 to 30 gram of endotoxin, and less than 0.001 gram of endotoxin is enough to kill a patient. So toramycin, it's the endotoxin, is indeed circulating in the body in 50% of sepsis shock patients. And toramycin is very effective in removing the endotoxin. That is the reason why toramycin has been tried and in septic patients, more so in the gram-negative sepsis. And intra-abdominal sepsis, where we believe gram-negative are the most common organisms. When it comes to different studies, one of the important study was UFAS, which came in 2009, which has shown some significant improvement when it comes to group. The mortality benefit was there, and secondary outcomes like hemodynamic length of ICU stay, all those things have shown some significant improvement. Afterwards, the same group of people have done Abdomix trial, which was in 2015. Here, the mortality benefit was not significant. Then afterwards, they have tried again with UFAS-2 with around 357 patients with suspected gram-negative sepsis. There also, the ICU survival was not significant, and even the different endpoint or different subgroup of analysis, length of ICU stay, and all those things also didn't show much of significant benefit. There comes the biggest trial, which is a randomized trial, that is a EUPHORUS trial, which was published in 2018. There was almost 194 patients. It was properly randomized, and actually these trials, they checked the endotoxin levels also. We believe when the endotoxin level is more than 0.6 to almost 0.89 or 0.9, we believe the level of endotoxin is significantly high, and these people should be benefited with polymyxin B. In those cases also, when they have tried polymyxin B cartridge or toramycin cartridges, they didn't show much of mortality benefit at 28 days. Afterwards, now the use of toramycin has significantly dropped throughout the world. Coming to the CytoServe, this is again a very promising hemoperfusion modality. This it removes most of the things like cytokines, bilirubin, like endotoxin, everything. Nowadays, if you see the most of the data throughout the world, it's being used more often compared to any other form of hemoperfusion throughout the world. So it can be done in the normal conventional hemodialysis machines, even in the heart-lung machines, and standalone therapy with any form of blood pumps. So it can remove cytokine, myoglobin, bilirubin, bile cells, ammonia. Most of the things can be removed. Apart from that, a lot of drugs which can cause bleeding, like if somebody is on rivaroxaban, ticagrelor, and urgently they require surgery. In those cases also, there is enough data to run a CytoServe, which can remove your rivaroxaban, ticagrelor, and all those things, where the chances of having bleeding decreases significantly, and it can decrease your damage-associated molecular patterns and pathogen-associated molecular patterns, which are more often associated in septic patients. But it doesn't remove albumin, coagulation factors, and physiological mediators. It doesn't have much of effect on the platelet count. So there are many studies. One of the studies from Austria, which was published in 2020, the recent study one, where they by doing CytoServe, they've seen a significant improvement in mortality. You see, 28-day mortality is significantly clinically significant when it comes to cytosol compared to non-cytosol patients. There are many other studies like Sadler and Fickes and Sadler and Kogelman. All those studies where it is controversial. Most of the studies they didn't show significant, statistically significant mortality benefit when it comes to cytosol. But there are few Indian studies. One of the study which was published by Dr. Yatin Mehta in World Journal of Critical Care Medicine. They have done cytosol therapy in 100 patients in ICU. What they observed is there is a significant decrease or reduction in 40% who survived, and even nearby 28% of patients who were given cytosol therapy within 48 hours of onset of septic shock has survived. So, which is a significant survival benefit when it comes to cytosol and to be used early in the septic shock patients. Similarly, there are many Indian studies which has been published. They are very small studies, but most of the studies have shown mortality or some subgroup benefit, like your length of ICU stay, pressure requirement, or oxygen requirement, and all those things. There is the most common dilemma when it comes to any form of hemoperfusion therapy in septic patient is when to start. So when I was searching for the literature, when to start, is there any literature? There is one thing called cytoscore, mainly used in case of cytosol patients. It is till now not validated. It has been published in 2021 in the Clinical Medicine Journal. What it is interesting in the way that they have made a different point scores are there, lactate change or lactate clearance, norepinephrine requirement, and change in the norepinephrine requirement, second catecholamine, hydropotassium use is there or not. After 30 ml per kg boluses, is there any improvement in blood pressure or not, or the patient required or not? On the basis of that, if the cytoscore in the first 6 hours is more than 6 points, they suggest to start cytosol in these cases. Can we replicate the same thing to other form of hemoperfusion therapy at this point of time? Not sure. And now for cytosol therapy itself, it is not validated. Maybe in near future, we'll have some validated scores. Maybe cytoscore can be validated in near future. Then we can have some answer when to start hemoperfusion in a sepsis and septic shock patients. Intraoperative use of cytosol therapy also they have studied, mainly in patients who are undergoing any cardiothoracic surgeries, like for infective endocarditis, aortic surgery, heart transplant surgeries. These people, they believe there are very high cytokine release, and to have that cytokine things, they have used cytosol therapy intraoperatively, and they have seen significant mortality or significant morbidity benefits. And whenever there is a high risk of bleeding in patients who are on ticagrelor rivaroxaban and they require emergency surgery, they have tried cytosol pre and post. They have checked those blood level of ticagrelor rivaroxaban, which has significantly decreased. The chances of bleeding has also decreased. So new indications are coming out when it comes to different form of hemoperfusion, and most of it cytosol. Place where they use cytosol, remove any of the drugs which cannot be otherwise removed with your common dialysis or hemofiltration. One more important hemoperfusion cartridge which is used in case of sepsis is oxyris. Oxyris basically have 3 layers. The first layer is a positively charged layer which takes care of the cytokines. The second is a negatively charged, first one is a negatively charged layer, and the second one is the positively charged layer which takes care or absorbs the endotoxin. The third layer, which is heparin coated, which is used as a normal dialysis filter. So it basically it can support the kidneys. We can do dialysis through oxyris cartridge. It helps in removal of cytokine, endotoxin, and because there is embedded heparin in that, it has local anticoagulant effect also. So the only disadvantage with oxyris is, apart from the removal of cytokine and endotoxin, it can remove few of the antibiotics or drugs like vancomycin and amikacin. It's not only in oxyris, maybe in cytosol and other form of hemoperfusion also, the drug dosing may get altered, and it can remove few of the drugs which are very important when it comes to treating a patient of sepsis. And how to adjust the doses when somebody is on some form of extracorporeal therapy is a questionable thing at this point of time. We don't have clarity on that. Maybe we can discuss further during our discussion part. I'll not go into detail about all those things. So there are few data where they have supported oxalis. Don't want to go to in detail about all those things. This is one of the study which was published in 2019, 60% sepsis, septic shock and AKI. And by doing oxalis, there is improvement in cardiovascular status. HA330 which has HA330, which has been approved for patients of sepsis and septic shock. It can remove both endotoxin and cytokines. There are few studies like in 2010 and 2013. Both the studies have shown significant improvement, both in survival benefit, hemodynamics, and length of ICU stay. LPS adsorber, there are very few studies where they have shown like questionable benefit. In few latest studies, didn't show much of benefit in survival. These are like, apart from, let's say, sepsis and septic shock, what we see most often in ICU, where we can think of using a hemoperfusion, which is not very clear at this point of time, because a few studies they support, but most of the studies are against at this point of time. Apart from sepsis, we can use this extracorporeal treatment in different forms of acute poisonings. You see, majority of exposure due to poisonous substances, they need only supportive care. Only extracorporeal therapy is required in 0.1% of intoxication. There is a group called the EXTRIP group, that's extracorporeal treatment in poisoning group, which was established in 2000. The aim is to clarify the role of this extracorporeal therapy in different form of poisonings. When and where to consider extracorporeal therapy when it comes to poison. It's a very interesting slide. You see, is the exposure of the poison likely to cause serious morbidity or mortality? If no, then there is no reason to think of extracorporeal therapy, because extracorporeal therapy has its own complications. And can the poison toxicity be prevented or reversed by an antidote by which the poisoning effect can be reversed? Then there is no reason to start an ACTR. And the poison toxicity can be minimized by treatment by decreasing their absorption or elimination by like activated charcoal, sometimes used in few poisonings, where can decrease that absorption of the poison itself. There again, ACTR doesn't have any role. If the poisonous endogenous clearance is very significantly high, there also we don't require. When the poison of volume distribution is significantly high, as I've told before, there may not be therapy. If those things are no, then we should consider about extracorporeal therapy. Then comes the how much of the poison or the drug what we are supposed to remove is protein bound. If it is more than 95% protein bound, then no form of extracorporeal therapy other than plasma exchange can remove those drugs. If it is 80 to 95%, we can think of different forms of hemoperfusion. If it is less than 80%, then comes the molecular size of the drug or the poison. If it is 15,000 Dalton, then high flux membrane can be used. From 15 to 25,000 Dalton, hemofiltration can be used. 25 to 50,000 high cutoff membrane, and more than 50,000, because the size is significantly large, any form of hemoperfusion cannot remove those drugs or molecules. In those cases, we have to think of therapeutic plasma exchange only. So most of the 95%, as I've discussed, most of the things here, I'll not go into detail about these things again. So you see, this is the up-to-date. These are the drugs which can be removed with some form of hemoperfusion. So most commonly has been used are like ethylene glycol poisoning, lithium salicylate, acetaminophen, ethanol, methanol. These are the most common drug intoxication where some form of extracorporeal therapy has been used more often. If you see different form of extracorporeal therapy in different poisoning, the most common form of extracorporeal therapy used is hemodialysis, then hemoperfusion, and other forms like our plasma. One of the well-established indication for hemoperfusion, one is paraquat. We know like paraquat poisoning, which we see on and off in our hospital, because like it is one of the deadliest poison available, but it's still available in our country, and it causes significant mortality in patients. And if present early, if we can do a hemoperfusion within 4 hours, they have significant mortality benefit. Organophosphates, we know that they have antidotes and all, but still in severe massive overdose, we see mortality. In those cases also, we can try hemoperfusion. Apart from that, carbamazepine, theophylline, and few of the other drugs also where we can think of hemoperfusion. Coming to the few studies when it comes to hemoperfusion paraquat poisoning, what they have seen is if you can do a hemoperfusion early, that is less than 6 hours, late hemoperfusion more than 6 hours. What they have seen is almost 92% of people survived if they could do a hemoperfusion early within 6 hours, whereas only 42% survived if they are in a hemoperfusion late, that is more than 6 hours. So time-dependent hemoperfusion after acute paraquat poisoning. Here they have done a hemoperfusion within 4 hours if the patient presented within 4 hours, and they've repeated one more cycle after 20 hours. By doing that, there is a significant improvement in mortality. There is like a Jaffron hemoperfusion cartridges, HA330, 230, and 130. 330 we have already discussed, which has been used in case of sepsis and septic shock. HA130 is an interesting thing which can be used in case of patients who are on chronic hemodialysis patients. Because of chronic hemodialysis, as I have told before, we can remove the small molecules, the middle molecules, which are the toxins related to uremia, cannot be removed properly when we are doing hemodialysis. What I have suggested is if you do a hemoperfusion in these cases, at least a weekly once or twice, they have seen significant improvement in their blood pressure management, their cardiothoracic ratio, their erythropoietic level, so hemoglobin level, all those things. After if you do a hemoperfusion in these cases who are chronically dependent on hemodialysis, at least weekly once. Similarly, HA230 intoxications, like different form of intoxication as we have discussed in paraquat, and acute severe organophosphorus poisonings also they have tried, where they have seen some significant improvement. One more important part is MARS, that is molecular adsorbent reticulate system. Here they have used hemoperfusion. The filters usually use the charcoal adsorbent and all, where the dialyzed is albumin, because most of the molecules which are important or the cause of hepatic encephalopathy, like our aromatic or branching amino acids, mercaptans, and all those things, which are highly protein bound, where can be removed by charcoal hemoperfusion. In the meantime, the dialyzed what they use most of the time is albumin. If we can do a hemoperfusion, we can remove most of these drugs, and also in the patients who are with hepatic encephalopathy can be benefited by doing a hemoperfusion. Sorry, hemoperfusion versus hemodiafiltration. Hemoperfusion is more effective, as we have discussed, in highly protein bound drugs, and is more efficient than hemodialysis in clearing lipid soluble drugs. But hemoperfusion has its own complication. If the substance can be equally removed by hemodialysis or hemoperfusion, hemodialysis is the modality of choice because it has less complication and time tested. So here, when it comes to hemoperfusion, we need to have a vascular access. Usually what we do, we keep our dialysis catheter only. We need to select the cartridge for what purpose we are using hemoperfusion. And these people will require some form of anticoagulation, maybe more than what they require during a normal hemodialysis. Usually what we use is heparin or citrate can be used. Blood flow, minimal blood flow around 200 to 300 ml is sufficient. In the meantime, the duration should be around 3 to 4 hours. What has been suggested is if you continue this hemoperfusion for longer duration, though surface area will be like saturated with the drug or the toxin. So beyond 4 hours, it is not much useful. But yes, in cytosol and all, they have suggested to continue for 24 hours. And maybe the case of the drugs are poison, which is having significantly in more volume of distribution, they require maybe multiple cycles of hemoperfusions. They require proper monitoring, more so with the drug level, as we have discussed. The drug level may drop, and we know most of the drugs we can't check the drug level, and it is not available also. But it is important that the drug level should be checked, or at least you should give like higher drug doses compared to a normal person when they are on hemoperfusion. The most common complication is thrombocytopenia, more so like with some charcoal compared to resin. Charcoal causes less thrombocytopenia. Hypoglycemia, hypocalcemia, and all those things can be seen when it comes to hemoperfusion. Plasmapheresis, with the interest of time, I think I will skip it. So basically, because we are mostly discussing about hemoperfusion things, so better, because interest of time, I need to skip that plasma exchange per se. So coming to my last slide, what is the take-home message? Not all poisons or drug overdose requires extracorporeal therapy. It is important to know about the toxicokinetic of the poison as well as the severity when it comes to a therapy of hemoperfusion in any form of toxin or poisoning. In severe poisoning, always think of extracorporeal therapy whenever it is feasible. Sepsis, different form of extracorporeal therapy, as we have discussed, has been tried. they actually, if you see the theory, it looks very promising. But most of the evidences are still lacking when in favor of hemoperfusion when it comes to sepsis or septic shock patients. Maybe in future, we can get some clear-cut ideas when and how to use this form of extracorporeal therapy. Still the concepts are evolving. Maybe future this thing may widen the indication safety and more and more robust data will come, by which will the things will be much clearer. With that, I'll stop here. Thank you. Over to you, Madhusudhan sir.
Thank you, Dr. K.C. Misra, for a very wide topic. This is not a small thing to cover, and a lot of ideas. A lot of people think filters means only for the dialysis, but I think you're given a lot of dimensions for the treatment in the ICU, and a lot of horizons have opened up. The concept is quite good. Just like the patient having a lot of infections are there, utilizing the concept of the diffusion, convection, what we are using for the dialysis and for taking care of the other molecules. The other concept, what you told about the drug overdoses and all things, I think it's quite newer concepts are there. But only whatever the theoretical concepts are there, whether translating into our day-to-day practice is important. For this, the discussion taking further, we have the two expert panelists available. Dr. Rajasekara Chakravarthi sir, who is the clinical director and the transplant physician nephrologist at the Yashoda Group of Hospitals. And welcome to Dr. Valentine Lobo sir. Actually, the initially discussion sir was not available. Sir is a senior nephrologist at the KEM Hospital, Pune. For taking further, I just wanted to ask Rajasekara Chakravarthi sir, the Misra has presented a nice concept, but the lot of acceptance, what we are seeing in day-to-day practice, still it is not there. What is your personal experience, sir, about the utilizing these different filters in day-to-day practice, particularly in the ICUs and critical care areas?
So thank you, Dr. Madhusudhan, and thank you, Dr. Misra. As Dr. Misra clearly told, there are many indications now accepted for filter use in the ICUs, and all of us have some experience. During the COVID time, there has been a significant experience with many units which saw COVID patients, which was one of them. And as a group of nephrologists, we have more than 100 sessions among us in the renowned clinical services. I should say there has been a mixed response. There are a lot of ifs and buts about when you should use a filter, and when you use it, how long to use it. Dr. Misra did convey some of the data, but I don't think there is any consensus that exists today which clearly gives us guidance. This is what you should do in this particular scenario. Just to mention, sepsis is one of the commonest cohort of patients where you and I would want to use it when other things like the antibiotics and fluid resuscitation, acidosis correction, all the other things have not helped. We may want to go ahead and look at using a filter. So the aim here is to remove certain molecules from the patient's blood compartment, which will allow the molecules to move from the tissue also. So there is a cytokine, let us say, for example, you want to move from the tissue and from the blood. You start removing it from the blood, but it gets refilled from the tissue. Why I brought up this concept is, in sepsis, one of the things that we thought a continuous renal replacement therapy with a particular filter would do is removing of these either cytokines or endotoxins. But the generation of the endotoxin or cytokine is not under our control. So you tend to remove certain things, but these things continue to be generated. So one of the questions asked is it really useful in removing them when you are not able to fully reduce the circulating cytokine or in the tissue cytokine because the generation continues? First question. Second question is, there are certain harmful cytokines and there are certain good cytokines. So one of the criticisms of using a filter in a septic cohort of patients is that when you remove both of them, you may be causing some harm also. So keeping this in the background, the indications for us to use are sepsis, and according to literature, cardiac surgery, organ transplantation, and in certain specific conditions, removal of a particular toxin or a drug or myoglobulin in conditions of rhabdomyolysis and so on and so forth. So I'm sure each one of us would have had some experience, but working towards a consensus with some guidelines saying in this particular cohort of patients, this is the filter to be used, this is the prescription, and this is the time duration. I'm not sure we are there yet, but there are certain things. For example, in COVID, if you had removed interleukin-6, we could do a interleukin-6 levels and then decide whether this patient needs it or not. So there are two indications in my mind. One is the biochemical indication, where you have a cutoff of endotoxin level of so much or interleukin-6 level of so much, or the clinical indication, which most of us would probably use, and many labs will not be able to give us the endotoxin level or a particular cytokine level. Regarding the filter per se, there are filters which will remove cytokines, there are filters which remove endotoxins, and there are filters which do both, like Oxidis. So that is what Dr. Misra has conveyed. So I think we can start off with this discussion, and anything more specific, we can talk about it.
Definitely. Thank you, sir, for giving showing the light and the discussion about the different ideas are there. Whatever Dr. K.C. Misra has presented the data, in that some subset of patients are showing the benefit, but we are not very clear, as you told, what is the time is there. Whatever we understood from this, maybe in the standard form of sepsis surviving guidelines, they're giving some guidelines for us to start the treatment and maybe adding an adjuvant therapy or what. Before discussing further points, we'll just take opinion from the Valentine Lobo, sir. What is your experience about using the filters in our day-to-day practice, sir, for the critical care areas?
Yeah. Am I audible?
Yes, sir.
Yeah. Okay. So using filters in day-to-day practice, I use Oxidis because most of the time, by the time I see a patient, the patient also has AKI and requires renal replacement therapy. So my indication is use Oxidis on the Prisma. Oxidis, unfortunately, can only be used on a dedicated system, Prismaplex. So I use Oxidis there as a renal replacement therapy, and whatever additional benefit of removing cytokines, endotoxin is additional benefit for me. We published a case report in Indian Journal of Nephrology of Oxidis effect on removing interleukin-6 in COVID, and we showed that in that patient at least there was an 85%, in those patients, we got an 85% reduction after 48 hours of Oxidis use, and it coincided with improvement in oxygenation in the PaO2, FiO2 ratios, etc. We also used hemophil in COVID. In the indication by then was if you have an IL-6 level of which is 50 times the upper limit of normal. So we did use it in 14 patients. The company very kindly provided us with free hemophil dialyzers, and hemophil can be used on an ordinary hemodialysis machine in a sled form. So we used it for about 8 hours on average, and again we had a good reduction. What we were also able to show, and that paper will come up for publication in 14 patients, that C-reactive protein, which is a large molecule, its molecular weight is about 160,000. So clearly it is not removed by any of the filters which are available. But what we were able to show was not just IL-6, but CRP also dropped dramatically after we had done 2 sessions of hemophil sled. Over the years, I have used many filters. In the last decade, we used, I would say the decade before last, maybe between 2005 and 2015, I used a lot of Torimixin. And then first Abdomix, and then Euphrates showed us that it did not work in randomized control trial. And as Dr. Misra very rightly said, we gave it up. I have not used a lot of cytosol. I've had bad experience, poor experience with it, though small experience. But also there was data which Dr. Misra showed, the study from Shadler, which was published in 2017, where the 60-day mortality was twice as high in the cytosol group as in the control group, and that was statistically significant. There's also another paper published in COVID patients and cytosol in Lancet Respiratory Diseases, I think 2021, where the mortality was 4 times higher in the cytosol group as compared to the control group. And this is what has dissuaded me from doing a lot of cytosol therapies. Though, as he pointed out, there are Indian studies, mostly observational studies, many of them retrospective small studies which have shown a benefit. So I said torimixin, I said cytosol, and I said oxalis, which is currently what we prefer, and hemophil. So hemophil looks like being a good option because once again, you can do the renal replacement therapy along with it and whatever additional benefit of cytokine removal we showed. To answer Dr. Rajasekara's question, because as he said, we don't know whether we are removing good as well as bad cytokine. So I believe that our small data which showed that the CRP, which was not removed by the filter, was coming down in the COVID patients, is indirect evidence that perhaps we were reducing inflammation by removing. Many years ago, Dr. John Kellum said that are you removing good and bad? When the patient has a high degree of inflammation, probably there is a predominance of bad cytokines over the good cytokines, which is why the patient is so ill in SARS or septic shock. So if something is in excess, when you are removing urea in a hemodialysis in a patient who has AKI, urea is very high, so you remove it more effectively. If the cytokines, the bad cytokines are in excess, they will probably be removed more effectively in such a situation. As regards IVORE, I used to do a lot of high volume hemofiltration till IVORE was published. In IVORE, there were many drawbacks to that study, but essentially it was the death knell for high volume hemofiltration. Now that study was designed to have about 460 patients, and in 5 years they were only able to recruit 141, and the study was abandoned for futility. Secondly, they had assumed that the control group would have a mortality of 60% and they would be able to show a 20% reduction in the high volume group. In actual fact, the mortality was 41% in the control and 38% in the high volume hemofiltration group. And the third thing, the drawback of that study was, which was mentioned, they did not increase the antibiotic doses. Now, when you go from 35 ml per kg per hour in the control to 70 ml per kg per hour, you are doubling your clearance of antibiotics as well. And that study did not increase the antibiotic dose in the high volume group, which could have been, commentaries have said that could have been a reason for their poor results in that study. So I gave up high volume hemofiltration because the guideline after that said it should only be used in the setting of a clinical trial and not as therapeutic treatment. There was one more treatment which I tried to do, and again, the two studies, Compact 2 and ROMPA, killed that therapy. That was coupled plasma filtration adsorption. And Meditronics, in fact, did not bring their CPFA machine to India because Compact 2 got published and it killed that form of therapy. So that has been my experience with these therapies.
Thanks a lot, sir. Thank you. Just wanted to ask question, sir. The one side we are measuring the level of the pro-inflammatory cytokines. After doing the filter, we are measuring that same level. But why is not able to translating in the practice for survival of the patient?
Yeah, that's a good question. And in fact, there is one study which showed that this did not, and that was a good study. It was called HYCORIS. It's published in American Journal of Kidney Diseases in 2016. They used high cutoff membranes along with high volumes, 40 ml per kg per hour versus 80 ml per kg per hour. And what they showed was that though they effectively reduced all the cytokines, there was no mortality benefit. The mortality was almost the same in both the groups. So probably, again, they did not measure what Dr. Rajasekara was saying. They did not measure the levels of good cytokines. Maybe they removed those equally. The second thing that study did not do again was to increase the antibiotic doses. When you go 80 ml per kg per hour, it is almost like normal creatinine clearance or normal renal function that you are giving those patients. So you would need to increase your antibiotic doses to normal or perhaps even supranormal, because you are clearing the water-soluble molecules in very large amounts. So that could have been one reason why many of the studies failed to show a benefit. There have been other causes which have been cited. The timing, we don't know the correct timing at which we should start. If you start too early, you will end up by picking patients who would have survived anyway. If you start too late, it's too late anyhow. So what is the optimum? We don't know. Euphrates tried to address that in terms of endotoxin by saying that 0.6 to 0.9, and that was based on the other study by John Marshall. I've forgotten the name of that study, which said that 0.6 to 0.9 was the area where tolimixin would work. But unfortunately, Euphrates could not show a survival benefit either. In fact, once again, it was 33% in the control group and 38% actually in the tolimixin group. So many of these studies have actually shown a slight signal of harm. And that is perhaps because they are removing good things like antibiotics, good things like growth factors, etc., which may be actually protective. That's what I feel at the moment.
Thank you, sir. I just wanted to ask Dr. Keshi Misra. Actually, the Rajasekara sir also told about we don't know the exact time when to start these filters and everything. What is my understanding is there, see, we are following the surviving sepsis guidelines. The guidelines has told us the first 1 hour, the resuscitation is this much. We have the target endpoints are there. After 3 hours, we are doing so much of resuscitation. We have the target endpoints at the end of 6 hours or 12 hours. I just wanted to ask Dr. Keshi Misra, what we understood from the discussion for last 45 minutes from your presentations and discussions and opinions of Dr. Valentine Lobo and Rajasekara sir. Suppose if you are not able to reach the targets within 12 hours, according to sepsis rule guidelines, that time, whether we can add this adjuvant therapy, provided that we done source control, provided that we have done adequate fluid resuscitation, provided that we are given the antibiotic. The only one clue what Dr. Lobo is suggesting, sir, the antibiotic doses, what we are giving suboptimal because of the creatinine and everything is there, maybe giving a normal doses or a supernormal doses. What is your opinion?
See, sir, actually, this is a question that still needs to be answered. Actually, we don't have a clarity on that. That is the reason I have shown one slide. It is not been published. I was searching in the literature. Actually, the cytos of people, they came to our hospital and there was a presentation from them. Actually, they were telling one score called cyto score, which I have shown actually. Actually, I have tried to search literature. I didn't get a literature on that. So cyto score, they have given 3 or 4 points. If you see, one is the lactate level, then the lactate clearance in 6 hours. Then after fluid bolus, the BP improved or not, the person required how many fluid boluses, like 30 ml per kg. So based on that, they have scored it actually 0, 1, 2 points. If it is more than 6, within 6 hours of initial sepsis and septic shock, they suggest to start hemoperfusion. If the patient is, again, if patient is AKI requiring dialysis, in those, there are some specific criteria, but they've like told, like in these cases, to start off hemoperfusion early than late. If you see most of the studies, wherever they have seen some beneficial effect, they've started early. That now the question is, like, if we start early, is it like too early we are starting, because of which we are seeing that benefit? Because not like every patient of sepsis are going to die. So if we are starting too late, is it like we are like we lost the time, and at that point of time, if you start also, the patient is not going to survive, because sepsis is a very complicated thing. It is not only one thing. By doing a hemoperfusion, removing the cytokines or toxins, everything will improve. So maybe at this point of time, the cyto score is one of the score which is there, which can, like, I felt like there are few valid things which can guide us to start some form of hemoperfusion. That is, cyto score is mainly meant for cytosol, but can be used for other hemoperfusion strategies also. But that validity, it is still under question. It has not been validated. Maybe in next few months that is going to be published. If it is really validated, then maybe we can try in our patient and see.
So, Misra, because you mentioned there is one paper which is now submitted for peer review and probably will very soon get published. This was a consensus meeting Ronco arranged in Rome. I was one of the faculty. They have given some sort of a consensus. This happened in November 2022, and the paper is now already submitted for publication. One of the things they have recommended is to move away from hemoperfusion as a term and call all of them as hemoadsorption. And among them, we will, as I just mentioned, sepsis, cardiac surgery, organ transplant, specific solutes, using something like a sorbent containing cartridge, wherein you have a broad spectrum solute removal because of the contact. So this is what their rationale is. And thus that paper talks about acute indications for these filters and also some chronic indications for these filters. I just saw one question in the question and answer, somebody asking about chronic indications. Anyhow, the summary, what Dr. Lobo, me, you, all of us discussed is, one, is there a timing when we can start? I believe we have to summarize saying clinical indication for timing, biochemical indication for timing. There will always be some particular substance which you want to remove, for example, myoglobin. In that case, the filter is going to remove what you know is there in the bloodstream. Similarly, in some patient cohorts, you may not have a level of a cytokine or a molecule. You will use a clinical indication. It could be what you just showed, a score, which includes a clinical status of the patient. You have done everything standard of care and patient is not improving, then you can apply it. So broadly, clinical indication and biochemical indication is what I have in my mind. Once we agree upon that, we talk of what filter for what type of disease. So for in sepsis, what are the filters? We already know there is an endotoxin filter, there is a cytokine filter, and there is a combination filter. Third is, how long would you do it? By and large, we started off doing for 2 hours. Now we are doing it for 24 hours. We know that some of these adsorption cartridges have infinity as far as adsorptive capacity is concerned. So that is the time. And then outcomes will depend on a lot of other things. One of the things Dr. Lobo clearly mentioned, and which is very, very important for you and me, even when you use a simple CRRT, please note what is the clearance that you are achieving and look at it as a GFR that you are adding on to the patient. Let us say most often with a 30 ml clearance, you are going to add around 10 ml or so of GFR. That has to be taken into consideration for your antibiotic dosing. So all those data from not only HVHF trial, other trials, where the antibiotic dosage was not adjusted, the outcomes were blamed on that. So probably this should be the approach. Clinical indication, biochemical indication, which filter, what is the molecule you want to remove, how long you want to do it, and how do you monitor and make sure your antibiotic dosage is not coming down.
I think
I just saw a question. Yeah, one of my favorite topics has been asked in the question. Someone says lactate is approximately 90 Daltons. It should be removed by most, but still we see a rise in patients who are on dialysis in sick patients. Now that's very interesting. The fact of the matter is that lactate is small, but lactate is, there are two things about lactate. That tissue clearance of lactate by liver and muscles is much higher than any form of renal replacement therapy. Lactate generation rates in a sick patient cannot be taken care of by any form of renal replacement therapy because it is coming from tissues. I think Dr. Rajasekara talked about this when he talked about cytokines in the tissues. In the same way, tissue clearance of lactate is very high in well-perfused tissues. And when you have a septic shock patient, when you have used high pressors, when your blood flow has been diverted away from skin and muscles towards vital organs, those muscles are producing lactate in amounts that no filter can take care of. And the moment you improve tissue perfusion, the lactate will be cleared because that tissue becomes much more effective. There was one study which was published in, I think it was published in Clinical Kidney Journal in 2016. They did something heroic. They put 2 femoral catheters and used 2 CRRT machines, one on each femoral vein. They gave 70 ml per kg per hour in one from one side and 50 ml per kg per hour from the other. So 120 ml per kg, very high volume, and still they were unable to reduce lactate levels. So that is the net generation rate of lactate in sick septic patients, which just cannot be removed and which can be removed. The same thing applies when we talk about this question. I'm asked sometimes, do your high volume hemofiltrations, can they produce hypotension by removing the pressors that we are infusing? The answer is no. Most pressors have extremely short half-lives and they are metabolized at the neuromuscular junctions at their site of action. So they will not be removed unless we have done something that we have placed our renal replacement therapy catheter alongside that same, in the same vein, alongside the catheter from which we are infusing the pressor. In which case, before the pressor has a chance to reach its site of action, we are pulling it out and clearing it through the filter. Otherwise, lactate and catecholamines are not cleared significantly by any form, even high volume hemofiltration, even hemoadsorption therapies. So that is the reason. Yeah, I like the idea of the cytoscope. I hope that the data will be published, which shows us that at different cytoscope levels when the therapy was initiated, what was the outcome, and that may give us a clue what is the right time using the cytoscope to initiate these therapies.
What we come to the conclusion about discussion about the filters and everything is there. What I understood, I'll put in that way. One important thing is there about the filters. One thing is there, what is the standard of care is there that has to go on. That is a basic thing is there. Source control has to be done. If you don't do source control, if perfusion is not improved, is no way lactate are going to improve for you. In the same way, the production of the cytokines, chemokines, if the infection source is there, we are not taking care of that removal of the source control done. The production of will be there. How much you take out from the filter, that is not going to help. That's what we come to the conclusion. So that in nutshell, what we discussed and what come to the understanding is there. Standard of care has to go on with the fluids, the antibiotics, the vasopressors, source control. In spite of doing all these things, we are not reaching to some level is there. I think that is the level you require an adjuvant therapy. That time we have to use the filter. That's what my understanding is there. And that's what the message will give for all the people. Now, the question comes about the Rajasekara sir has told about which filter, when and what. Now, the filter which are there, available are there, as sir has told about Rajasekara sir and the Valentine sir. When patient requires an renal replacement therapy, then we have to use the filter which is doing important for dialysis purpose and removal of your cytokines and chemokines. The other filters are there, just wanted to take opinion of Rajasekara sir about the other filters, how we can fit. If the patient requires dialysis, okay, we'll do it. Some of the patient doesn't require dialysis. Then where will fit that filters in our day-to-day practice? After doing the standard of care, we came to the understanding that after doing standard of care, we are not able to reach to a certain stage. That time we require adjuvant therapy in the form of filters. Now, if patient doesn't require dialysis, then what other filter has to be used? What is your opinion, sir?
So I think we partly discussed that. I can remember one patient who had a toxic fume inhalation, young man, 32, walked into the hospital, went on ventilator, then he was on CRRT, he was on ECMO, he was on polymyxin also. He walked home after 14 days in the hospital. So if there is no dialysis requirement also, you can always use these filters. It is like simple. In heart failure nowadays, you have what is known as for only ultrafiltration removal. Traditionally, what we used to do is cuff. Similarly, large volumes of water and salt can be removed with a filter. It's called aquapheresis. So for 48 hours, you can run that filter and remove. In one patient, we removed up to 8 liters or so. So whether patient requires dialysis or not, I don't think will change your indication or your using of any other filter if there is an indication. Septic filter can be used for somebody who does not have, and Dr. Lobo shared his data. And in COVID times, we had done for patients who did not need any dialysis, only the hemophil and other things we have used time and again, which in some patients having significant benefit. So irrespective of whether patient is on dialysis or not, you can put them on a circuit and use a filter and see what happens. Many times, should we do a single session or should we repeat it again? That depends to some extent on the patient's, how he behaves. And if you are using a biochemical indication like interleukin 6 or any of the other ones, you may have to recheck that and then decide to restart the therapy again.
Thank you. Misra,
can I ask one thing, sir? Apart from sepsis, like let's see, in nowadays one more filter which is available, that is Terra Nova. I think it is a high flux or high cutoff membrane. So I think that is been indicated. We have used in one case of severe myoglobinuria and like rhabdomyolysis patient. What is your experience, sir, in those kind of cases? How far it is beneficial? Like, because we have used and we didn't see much of benefit. The CPK levels were decreasing, but clinically, like, is it going to translate in clinical benefit?
So we recently used Terranova for one of our cardiologist sister who came with myoglobinuria and AKI starting. So the biggest benefit of using Terranova for a myoglobinuria patient is to avoiding full shutdown. So what we call as a pigment nephrotoxicity, pigment nephropathy. Compared to other types of ATN, these pigment tubulopathies take much longer to recover from shutdown. They become anuric. They go on dialysis sometimes for 4 weeks, 8 weeks also. So once you have a biochemical value of a myoglobin level being higher in the blood, without waiting, we would want to do the filter, reduce the burden of the protein. That will help in subsequently preventing a renal shutdown. If you use it after there is anuria, probably there is not much role, because already established ATN is there and it's going to go through its own course of recovery. But if you use it early enough, when still the urine output is good, and our experience has been it's a very good filter for that. I should also mention it can be used in certain chronic situations. So dialysis vintage, we do have patients who get into beta-2 microglobulin accumulation and all that. So there are chronic indications for it and there are acute indications for it.
Yeah, I have used Terranova, and the other one which Dr. Misra, I think you mentioned, that was Theralite, which was available some years ago. So the other indication I have used Terranova for is removal of light chains. When the free light chain ratio in myeloma patients is more than 100, then along with chemotherapy, you can improve the recovery of acute kidney injury in myeloma kidney by removing excess of light chain. So we have done it in patients. The normal free light chain ratio is 1.5 to 3.3 when there is any form of renal insufficiency. We've had patients with free light chain ratios of 4,000. And you use Terranova for about a month alongside chemotherapy, and those ratios come down to normal, and there is some amount of renal recovery. Myoglobin, I have not had the experience because, as Dr. Rajasekara said, within 8 hours, myoglobin will deposit in the kidneys if it is not treated in time. So you have to start with post-alkaline diuresis perhaps very early, and then add on filter like something like Terranova. The advantage of Terranova over the Theralite used to remove albumin. It had a cutoff of something like 110,000. Terranova they have modified, so its cutoff is at around 45,000. So just above lambda light chains, which are at 44,000, and albumin, which has a molecular weight of 66,000, is not removed by this. So you don't need to replace albumin. So that is the biggest advantage. As he said, I've also used it for beta-2 microglobulin accumulation in chronic dialysis patients. So these patients who develop dialysis amyloidosis, arthritis due to deposition of beta-2 microglobulin, that is where Terranova we have used as an adjunct therapy in chronic dialysis patients. Will it be useful in removal of cytokines? Theoretically, it appears, because most of the cytokines have molecular weights between 18,000 to 30,000, 18 to 30 kilodaltons, and Terranova's cutoff is at 45,000. So perhaps it will be useful. There are no large studies. The biggest study of Terranova in acute use is 7 patients. So there are no studies as yet. Perhaps we need to generate that data.
Actually, we have used in one case, maybe we had started little late in a case where we thought of crush injury of the leg, where we were thinking about myoglobinuria, CPK was high, but maybe we started little late, and patient landed up in AKI. Even if the CPK levels were coming down, we continued to require dialysis. Even we have used Terranova in 1 or 2 cases of sepsis, even in paraquat poisoning also, but unfortunately it didn't translate to a clinical improvement. Sir, one more thing, actually, like apart from our hemoperfusion, when it comes to plasma exchange, let's say plasma exchange can be done maybe in myeloma related hyperviscosity or like hypertriglyceridemia and all those things. Like when we can remove the whole of the plasma, where it contains all those cytokines and whatever it is, and replace it with the normal plasma, how it is going to be benefit in this kind of, let it be poisoning or let it be in sepsis also? Any data on that, sir? Because I didn't get much of data when I tried to.
Yeah, so I was a big enthusiast of plasma exchange in myeloma. Until that study, which was published, now it's almost 15 years. The study there was a randomized control trial of adding plasma exchange to standard of care in myeloma. Johnson's study in Annals of Internal Medicine, which failed to show a benefit of plasma exchange. And that was what removed plasma exchange from the treatment of myeloma. Is it going to be, what was your other question about myeloma was one?
Like in the toxins, like let's say in paraquat poisoning and all, we are trying for hemoperfusion, but do you believe like this plasma exchange can help, sir?
Yeah, so
sometimes we are getting difficult.
Yeah. The question is, how much volume of plasma exchange will you do? As you have said in your lecture, and Dr. Rajasekara also said, the hemadsorption filters seem to have an infinite or a very large capacity to remove. When we do plasma exchange, if we are doing one plasma volume at a time, we will produce around a 65% reduction in most of the protein components of plasma, and therefore the protein bound toxins. If we do 2, it goes up to 78%. And when you reach about 5, it is about 90%. Now, one place where I do use plasma exchange and high volume plasma exchange, that is 15% of the body weight. So for a 60 kilo adult, that comes to about 9 to 10 liters of plasma exchange, is in acute liver failure and acute on chronic liver failure. The study by Larsen showed that the survival in these patients, even without liver transplant, was significant. So we do offer high volume plasma exchange for 3 consecutive days, 9 to 10 liters per day, to patients with acute liver failure and acute on chronic liver failure, with some good results. Larsen study showed a 58% 30-day survival, which in acute liver failure is extremely good. So that is what has led us to using this. But the volumes have to be large. When you use large volumes of plasma like 9 to 10 liters, you have to use fresh frozen plasma at least as part of the replacement, because otherwise you deplete all the coagulation factors, all the immunoglobulins, everything. So you not only have to use albumin, you have to use fresh frozen plasma. And technically, when you go to those volumes, it is not easy to do, especially if the patient has a coagulopathy. You cannot use an anticoagulant. Dr. Rajasekara might be having some experience of using regional citrate in these. I do not. I have not yet used regional citrate for plasma exchange. So if you have the expertise for using regional citrate and plasma exchange in high volumes, perhaps there will be a benefit. But the standard plasma exchange of one plasma volume, which is about 40 to 50 ml per kg body weight, is pretty good. And that doesn't seem to work. If there, hemadsorption is much more effective.
Misra ji, we do have a lot of experience with plasma in organ transplantation, because nowadays we are doing ABO incompatible transplants. So we always do plasma to reduce the antibody levels, and we have good results. But what Dr. Lobo shared with you now is other indications and large volumes. Technically, it is feasible, and I think we have not used plasmapheresis for acute liver failure. But in many other conditions, I think plasmapheresis will come slowly, including in septic individuals. There is very small data that plasmapheresis can be used in septic shock when other things have failed, with some reasonably good results, but there is no consensus about it. My own understanding is, as plasmapheresis, now there are so many varieties: double filtration plasmapheresis, heparin-induced extracorporeal LDL precipitation apheresis, combination EB, a lot of things. I think in most of once the standard of care is given, if somebody does not improve, plasmapheresis and other things are going to come into vogue, though they are not a recommendation as of now. The KDIGO paper on AKI talks it as a suggestion. In some patients, they may be useful. And this Ronco's paper I've told you now is going to come as indications for acute and indications in chronic. And I believe it is going to be standard of care in future. A lot of companies are investing into it. John Kellum is now joined a company called Spectra, which is again a filter. And Ronco is on the board of this Jaffran. So I believe a lot of interest in filters, and we have to learn to use them. And as I already told, indication, what filter, when, how long, and how do you monitor? These things is what we have to learn over a period of time.
Yes, sir. That's what actually I'm very much fascinated when it comes to extracorporeal therapy, let it be hemoperfusion or plasma exchange. Because maybe what I believe in plasma exchange, I may not be the right person being nephrologist there as a panelist. So if the volume of distribution is not significantly high, or let's say significant protein bound is there, maybe plasma exchange will be more helpful. And is Sir Lobo sir told, I think the latest ASFA guideline, which was published, the guideline in 2019, in acute liver failure with maybe hepatic encephalopathy, it is in the controversial stage. At this point of time, it has not been categorized. And patients who undergoing AVO incompatible transplant patient, those I think in category 2 it comes, sir, if I am not wrong. So actually those slides were there. I just skipped those things because it already I was exceeding my time frame. Sir, like regarding high cutoff membrane, sir, like how frequently you use, sir, high cutoff? Because the nowadays effort from Terra Nova, which is a form of high cutoff, before have you used, sir, high cutoff or high flux membranes? Like
so Dr. Lobo mentioned Teralite. We have in hyperviscosity syndromes, if I remember right, 2 patients, and recently for one hypertriglyceridemia also we have used. So Dr. Lobo must definitely has more experience. Dr. Lobo, anything?
Yeah, the high cutoff membranes, the ones which were used in the trials which you mentioned, Dr. Misra, that was the Septex membrane, that never came to India. So Theralite are used in myeloma. The problem was that Theralite was extremely expensive. It was 90,000 rupees for that membrane. And Baxter had, Gamro in those days, had labeled it as single use. So we used to reuse it in the patient's interest. We could not really go for 90,000 use this and single use. Terra Nova is much cheaper. It's 3,800 rupees is what it costs. So that's a high cutoff membrane, which is really affordable, I think. And this polymethyl methacrylate hemophilia is also a high cutoff membrane, which is for use in the SLED mode. So you don't need convection. In fact, they say don't use it. The company has said don't use it in convective mode because it's high cutoff enough that in diffusive mode it will produce enough of clearance of large molecules. So these are the 2 membranes which I have an experience with. Septex, as I said, never came to India, so we never used it. But that was the membrane which was used in the high cost study which you quoted. So there is a study, ongoing study right now with the Septex membrane. It's a proof of concept study which we should be seeing in a couple of years. A small proof of concept study of over 40 patients. I saw it on clinicaltrials.gov. So that study we should get published.
Sir, last question from my side actually, sir. What is like your experience when it comes to hemoperfusion and paraquat poisoning, sir? Of late, we are seeing a lot of paraquat poisoning in our hospital, and we are collecting all the data. We are trying to publish one. We had almost now around 100 plus paraquat poisoning. The people who survived is less than 10%, and maybe when somebody is presented less than 8 hours, we have tried hemoperfusion also. But even after hemoperfusion, a lot of people they didn't survive. What is your experience, sir, in like Rajasekara sir or Valentine Lobo sir? Anyone can answer.
Paraquat per se, not much experience. Lobo, anything from your side?
No, I also do not have much experience with paraquat. I have not seen more than about 3 to 5 patients in all these years. And most of the time when I see them, they come because we are a reference center. So they come from the periphery. They have already been treated outside. And so, Dr. Misra, you're very lucky or unlucky. I don't know to be having so many patients. Yeah, unlucky.
We are unlucky.
Because unlucky. But we have not really seen it. And when we did see it, it was too late to do much. So it was more of organ support, and yeah, pulmonary fibrosis sets in, then there is nothing you can do. So high mortality is still, I think, the norm with paraquat. Maybe there will be people in other parts of the country who have used hemoperfusion with better results. I don't know. But our experience is very good.
Thanks a lot, sir. We had a very enthusiastic discussion and generated many points for the discussion. Starting from nowhere, because we did have the concept about using the filters in the ICU, and we came to the conclusion about the biochemical parameters, clinical parameters, when to use the filter, what indications are there. And I think is an evolving subject is there. As we use more and more filters, we have more and more data in our own country itself. I think all people coming together, if you are using the filters in the all over India, around 50 to 60 filters, ourselves in the Yashoda group of hospitals and KEM hospitals, I think by the next year in 2024, we'll have enough data. We had more than 1 hour discussion regarding about the filters. I thank a lot Dr. Rajasekara sir and Dr. Valentine Lobo for taking out your valuable time from your busy schedule and enlightening us about the filters in the ICU and given a lot of thought process. I think we'll plan in the future about one research meeting other than this, and we'll plan one protocol to utilize in the filters, because ours is a high volume center. We can exchange our thought process and knowledge is there, when to use, what to use, and we can generate our own data instead of relying on the people giving the data from the Western. With this, I thanks everyone, Dr. Misra for presenting a nice discussion. Thanks Rajasekara sir, and thanks Valentine Lobo. I will end the session here.
It was a pleasure.
Nice seeing you, Lobo.
Thank you, sir.
Okay.
Good night.
Good night.
Good night, sir.